Hello, I'm Antoni Chan. I'm consultant rheumatologist in Reading, United Kingdom, and I'm here reporting from the ACR 20. There are interesting abstracts again today in the aspect of spondyloarthritis, and I wanted to share with you some of the latest data from the study shown. Now, one of the challenges that we face globally is the delays to diagnosis in axial spondyloarthritis. Despite our many interventions, the average delays to diagnosis, certainly across many countries, can be somewhere between 8.5 to 10 years for ankylosing spondylitis. And there are a lot of new initiatives worldwide. Certainly in the UK, we have just launched our new drive to reduce the delays to diagnosis. And when we look at what happens on the ground level, we often see patients with undifferentiated chronic back pain, and we try to distinguish whether they have mechanical back pain or inflammatory back pain. There exists quite a few criteria for inflammatory back pain, such as the Kaelin criteria, the Berlin criteria, the ASAS criteria. In poster 1303, Weber and colleagues very nicely studied the sensitivity and specificity of the various different inflammatory back pain criteria. What they did was from the SASPIC study, they looked at patients with undifferentiated back pain who were less than 45 years of age and had features of inflammatory back pain for 3 months or more. Now, these patients had either anterior uveitis, psoriasis, or inflammatory bowel disease. So they had an extra-articular feature of axial spondyloarthritis. And when they had the presence of inflammatory back pain together with these extra-articular manifestations, they then used the different criteria to see which had the highest specificity and sensitivity of eventually having a diagnosis made by a rheumatologist as to having a diagnosis of axial SpA. And they found that in the psoriasis patient, they detected 45% of patients a new diagnosis of axial SpA, 62% in the uveitis group, and 40% in the inflammatory bowel disease group. When they looked at all the different criteria, it appeared that the criteria that worked best in terms of sensitivity and specificity was the ASAS modification of the original Berlin criteria. What is the ASAS modification of the Berlin criteria? This is when inflammatory back pain is no longer the mandatory feature of the criteria, and inflammatory back pain becomes an SPA feature in the criteria, as opposed to the original Berlin criteria where IBP is the mandatory feature. When the ASAS modification is made to the Berlin criteria, the sensitivity is about 76% and specificity 77.3%. Now, this works quite well compared to some of the other criteria that they used in the study. So again, I think when we try to reduce the delays to diagnosis, we perhaps should be thinking about which criteria we use, how we use it in our clinical practice, and which groups of patients we would target. Another interesting study, thinking in terms of delays to diagnosis and how we can reduce that, is poster number 1306, where they looked at patients who presented to the ophthalmologist with acute anterior uveitis with chronic back pain. They found that 53% of these patients who had uveitis had inflammatory back pain, and the HLA-B27 positivity was about 56%. And when they looked into these patients and they had investigations and also they were looking for axial spondyloarthritis, at the end of the study, 23% of the patients who presented had a definite diagnosis of axial spondyloarthritis. So 23% of patients who with uveitis presenting to the ophthalmologist were eventually diagnosed by the rheumatologist as having axial spondyloarthritis. But interestingly, 41% also were not diagnosed at the time, but probably had probable axial spondyloarthritis and would then require some follow-up. So in total, 64% of the patients who presented with anterior uveitis had features of either definite or probable altogether axial spondyloarthritis, and the delay from the onset of the back pain was 10 years. So I think these studies today, these two posters, perhaps will shape our kind of thinking about how we can reduce the delays to diagnosis. Firstly, having sensitive and specific criteria so that we are sure about who we should go on to investigate further. And maybe secondly, thinking about how we can work together with our ophthalmologists, our dermatologists, and also our gastroenterologists to kind of work together to ensure that these patients who present in another specialty could then be referred or screened, and to ensure that we can pick them up as they may have axial spondyloarthritis, first presenting with an extra-articular manifestation. So hopefully we can pick some of these points up and then try to bring it back to our clinical practice to reduce the delays to diagnosis. I'm Antoni Chan. Thank you very much for listening. I hope you enjoy the conference.